Assalamu alaikum wa rahmatullah. The second lecture in hemolytic anemia. One of the classical examples of defective metabolism of RBCs leading to hemolysis is glucose 6-phosphate dehydrogenase deficiency. And as you know from your previous studies, G6PD function to reduce NADP to NADPH. And NADPH is crucial for the RBCs to neutralize the oxidant stress. So when the oxidant come to the cell, NADPH give H and make water with the oxidant stress. So neutralization occurs. And NADPH is the only source for production of glutathione, reduced glutathione. Deficiency of this enzyme renders cell prone to or exposed or susceptible to oxidant stresses. Inheritance of G6PD deficiency is sex-linked, so males are affected and females are usually carrier with half of their enzyme values only deficient. So males are suffering from the disease usually. The female, which are heterozygotes for the abnormality, have an advantage of resistance to falciparum malaria because the falciparum malaria is sensitive to oxidant stress, and there is no NADPH available inside the cells of these patients to reduce oxidant stress. So the falciparum malaria suffers from oxidant stress and die. So the patient is not usually affected or is protected from falciparum malaria. This is the prevalence of G6PD around the world, and as you can see, mainly Africa and Asia are affected by the incidence of patients affected. There are so many agents that causes hemolysis in G6PD deficient patients. Number one, infections and acute illnesses like ketoacidosis. Drugs are there are so many drugs which are giving hemolysis in these patients, including antimalarials, sulfonamides, some antibacterial and analgesics like aspirin and favapine, a type of food which can precipitate acute attack of hemolysis in these patients. Clinical features of the disease. The deficiency can be asymptomatic unless the patient suffers from oxidant stress leading to hemolysis. So acute hemolysis and anemia in response to oxidant stress can occur in these patients, but it's not found all through the time, only in response to oxidant stresses. In between the oxidant stresses, there are no abnormality, there are no anemia. The patient may suffer from neonatal jaundice early in life, and rarely the patient may have a sort of congenital non-spherocytic hemolytic anemia. But the usual thing is that these patients are normal without anemia till oxidant stress occurs and it is followed by acute hemolysis, which may be fatal sometimes if not urgently treated. Diagnosis of the disease: between the crises, the blood count is normal, as we mentioned. The patient may not suffer from any problem unless he is exposed or prone to or get some sort of oxidant stress. We can make G6PD enzyme assay, and it is expected to be, of course, deficient and low. Number 3, during the